Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
her left hand.
45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. Today we're tackling one of the most intense and just rapidly changing periods of human development. Infancy.
That's a huge topic.
It is. We're talking about the child from birth, right after that immediate neonatal period, all the way up to their first birthday.
Right.
And our listener is really focusing on high-yield pediatrics, which means we're not just memorizing facts. We're trying to nail down that 20% of knowledge that really drives 80% of your clinical judgment.
That's the Pareto principle in action, and it's perfect for pediatrics. When you're dealing with an infant, everything is fluid. Their size, their vitals, their whole relationship with the world is changing week by week.
So what's our mission today?
Our mission is to integrate all those core requirements. We're talking health promotion, growth, development, and of course, safety, and look at them through the lens of a nurse who's providing anticipatory guidance.
So you're always one step ahead.
You have to be. If you can anticipate the milestones, you can anticipate the risks, and that really is the definition of great pediatric care.
Okay, let's unpack this. We're going to start with the real fundamentals. The measurements, the physiological baselines.
The numbers.
The numbers. And we're going to get into the specific ranges and, the assessment techniques that really help you distinguish a sick infant from a healthy one.
And this is high yield from the very first minute. For anyone prepping for a PEDS rotation or an exam, just understanding the age breakdown is the first step.
You mean newborn versus infant?
Exactly. The newborn phase, so birth to about 4 weeks, has slightly different parameters than the infant phase, which is 1 month to 12 months.
And that's an NCLEX trap right there.
It's pure NCLEX gold, because if you misinterpret a vital sign range, you could end up with a totally inappropriate intervention.
Okay, so let's start with heart rate. We all know infants are fast, but what's the actual physiological reason behind that? And what's that high yield range we need to know?
The standard infant heart rate range is 90 to 160 beats per minute.
90 to 160.
And the physiological why is really the key here. Infants have a pretty fixed and small stroke volume. That's the amount of blood pumped per beat. So to maintain their cardiac output for their, incredibly high metabolic needs, they have to rely on a fast heart rate.
So their little engines are just running on high RPMs all the time.
Pretty much. And their nervous system doesn't have that mature inhibitory control that older kids and adults have.
Which means if the baby is even a little bit stressed or crying or has a tiny fever, that rate can just skyrocket.
Precisely. And that's the critical nursing implication. Your assessment has to be accurate.
Right.
A reading of, say, 170 while an infant is screaming is clinically kind of useless until you address what's causing the screaming. You have to get that heart rate in a quiet, non-crying state to get a true baseline.
Okay, so moving on to respirations. This is another area where they're just different. They don't breathe like we do.
Not at all. And that changes how we assess them. The infant respiration rate is typically 25 to 60 breaths per minute.
Wow, that's a huge range.
It is, and it reflects those metabolic demands and their physiological immaturity. Two things are really paramount here for a nurse to remember.
Okay.
First, infants are obligate nose breathers for the first few months.
Which makes a stuffy nose a huge deal.
A very big deal. And second, they are primarily abdominal or diaphragmatic breathers. You assess their rate by watching their belly rise and fall, not their chest.
I often hear about periodic breathing. Is that something to worry about, or is it normal?
That's a great question. It causes a ton of parental anxiety. Periodic breathing, which is just short pauses in respiration, is a completely normal thing in early infancy. It's just due to the immaturity of their central respiratory control center.
So what's the cutoff? When does it become a problem?
The pauses usually last less than 15 seconds. If a pause lasts longer than 15 seconds, or if you see it with cyanosis or bradycardia, that immediately becomes an apnea event.
And that's a serious red flag.
An immediate intervention is required. Knowing that 15-second cutoff is absolutely key.
Okay, now, blood pressure. As a student, it always felt like this was the vital sign we kind of glossed over in a healthy, non-critical infant.
That's a really sharp observation. And you're right, in non-critical settings, BP measurement is often deferred. It's hard to get an accurate reading. The baby's moving, finding the right cuff size is a pain.
So why do we even need to memorize the range?
Because it's a classic NCLEX trap to think it's unimportant. We need that range because if the infant is sick or has a known cardiac history, getting a baseline becomes absolutely non-negotiable.
And what's that key baseline number we should have in our back pocket?
For an infant, so 1 to 12 months, you want to anchor to the average, which is around 85 millimeters of mercury systolic.
Okay, 85.
And about 50 millimeters of mercury diastolic. If a baby comes in with poor perfusion, lethargy, known heart issues, a drop below that baseline is a huge sign of circulatory compromise.
Got it. So for healthy babies, we're looking more at perfusion signs, but for sick babies, we need that number.
You got it. Cap refill, skin color, alertness. Those are your go-tos in the well-child clinic.
Let's shift to temperature. This one feels tricky because it's so dependent on age and where you're measuring it.
This is pure, non-negotiable clinical knowledge. For routine checks, the axillary route, under the arm, is the least invasive and it's the preferred method.
And what are we expecting to see there?
For a 3-month-old, the expected axillary temp is around 37.5 degrees Celsius or 99.5 Fahrenheit.
Okay.
By 1 year, it's a little higher, around 37.7 Celsius or 99.9 Fahrenheit.
And when do we ever use the rectal route? I know it's generally avoided.
It is. The nursing implication here is crucial. Axillary is your standard. You only go to a rectal temperature when an exact critical core measurement is absolutely necessary.
Like in a suspected sepsis case.
Exactly. An infant comes in with signs of sepsis. You need to confirm that fever to get treatment started fast. We minimize it because there is a small but real risk of mucosal trauma, and it's just really distressing for the baby.
So now for growth. It's just exponential in this first year. We need a simple way to remember all these numbers.
You do. Let's use what I call the tripling, doubling, and 50% mental model.
I like it. Tripling, doubling, 50%. Let's start with weight.
Okay, so we anchored to the average newborn weight of about 3,400 grams or 7.5 pounds.
Right.
The pattern is weight doubles by 6 months.
Doubles by 6 months.
Then it triples by 1 year.
Triples by 1 year. Simple enough.
But the immediate nursing priority here is actually the weight loss in the first few days. Newborns can lose up to 10% of their birth weight.
That must be terrifying for a new parent. How do we counsel them on that?
We give them that anticipatory guidance. We tell them it's completely normal. It's due to fluid shifts while the milk supply comes in, but we stress the recovery timeline. They have to regain that weight by the 10th day of life.
If they don't?
If they haven't regained their birth weight by 10 to 14 days, that's a serious nutritional red flag. You have to evaluate for breastfeeding issues, formula intolerance, something metabolic. It's a critical check at that first well-child visit.
Okay, what about length?
Length increases by 50% by 12 months. So if they start at, say, 50 centimeters or 20 inches, we expect them to be around 75 centimeters by their first birthday.
And finally, head circumference. You could argue this is the most important measurement of all in the first year.
It's absolutely critical. It's our best external indicator of brain growth. The average at birth is 35 centimeters, and it increases by a staggering 10 centimeters in the first 12 months.
Wow.
That tremendous growth just underscores the rapid brain development and myelination happening inside. If those HEC measurements lag, or if they jump up too fast, it could signal microcephaly or hydrocephalus.
Let's talk about the physical signs of that growth, the fontanels. They're like little windows into the baby's hydration and intracranial pressure.
They are a critical clinical check. You have to know the closure timeline. The posterior fontanel, the one in the back, closes first and fast, usually by 2 to 3 months of age.
2 to 3 months, okay.
The anterior fontanel, the big soft spot on top, closes much later, anywhere from 12 to 18 months.
So if I'm assessing a 6-month-old and I can still feel an open posterior fontanel, that's a red flag.
Precisely. That suggests a potential issue, maybe a skeletal disorder or delayed bone maturation. And clinically, you have to remember your assessment findings. A sunken fontanel suggests dehydration. A bulging fontanel, especially if the baby is quiet, suggests increased intracranial pressure.
Right.
And that needs immediate follow-up.
So we have all these numbers: weight, length, head circumference. But the priority isn't just taking the number, is it? It's about what you do with it.
Absolutely. The nursing responsibility is meticulous plotting on standardized growth charts. But here's the key clinical insight. We're looking for consistency, not perfection.
What do you mean by that?
A baby who is consistently tracking along the 10th percentile is often perfectly healthy. The red flag is a significant deviation from their own previous trend.
So a baby who is at the 50th percentile and suddenly drops to the 5th.
That's the one that needs an immediate investigation for failure to thrive, chronic illness, or, nutritional neglect. It's the change in the curves that matters most.
This next topic, adjusted age, is where I know students get tripped up, but it's a high-yield calculation for preemies. What happens if we forget to use it?
The consequence is critical. You could misdiagnose a developmental delay. If you assess a 6-month-old preemie against the milestones for a full-term baby, you're almost guaranteed to find them delayed. This leads to unnecessary referrals, a ton of parental anxiety, and interventions that maybe weren't even needed.
So it provides a more accurate roadmap.
Exactly. And we use this adjustment until the child is 2 years old.
Can you walk us through the calculation step by step?
Sure. So first, we're talking about infants born before 36 weeks gestation. The calculation is 2 steps. 1, figure out how premature they were. Subtract their gestational age at birth from 40 weeks.
All right.
2, calculate the adjusted age. Just subtract the number of weeks they were premature from their current actual age.
Let's run the numbers on a classic example.
Perfect. Imagine you have an infant who is 6 months old chronologically, so 24 weeks old, but they were born at 32 weeks gestation.
Okay, so they were premature.
Right. Step 1, 40 weeks minus 32 weeks is 8 weeks premature. Step 2, their chronologic age is 24 weeks. You subtract those 8 weeks of prematurity, their adjusted age is 16 weeks, or 4 months.
So when we check to see if they can hold their head steady or sit up, we're comparing them to a 4-month-old, not a 6-month-old.
Exactly. And that distinction is just vital for providing accurate guidance and assessment.
All right, so once we have that physical baseline, we start looking at function. And development isn't random at all, is it?
Not at all. It follows this predictable internal choreography that nurses just have to anticipate.
Here's where it gets really interesting. The predictable choreography of infancy. Let's start with that mental model for how development progresses directionally.
Okay.
So why does head control always come before walking?
Because gross motor skills, those big movements, develop in a cephalocaudal direction.
Head to toe.
Literally head to toe. Think of it like building a skyscraper. You have to secure the top structure, the head and neck, before you can support the foundation, which is the legs and walking.
And what about fine motor skills?
Fine motor skills, the really precise hand and finger movements, they develop proximodistal.
Center to periphery.
Exactly, center to periphery. So they gain control of their shoulder and arm first, the proximal part, before they can refine the skills in their fingers, the distal part. It's like moving from swinging a bat to holding a pen.
Okay, so let's lock in on those NCLEX-focused gross motor milestones. These are the landmarks that really drive the safety conversation with parents.
These are the high-yield checkpoints you must know. So if 2 months, they can hold their head up when they're on their tummy.
That's that first cephalocaudal win.
It is. At 4 months, they have steady head control without support and can push up on their forearms. This is really the last point where a little bit of head lag is okay.
Got it.
6 months is a huge month. The infant masters rolling over, usually from their tummy to their back first. They also start to sit in that tripod position, leaning forward on their hands.
And that's when the safety guidance just changes completely.
Dramatically. Now they're mobile. Then at 9 months, the child can sit totally unsupported and can get into a sitting position on their own. This frees up their hands to explore.
And 12 months.
By 12 months, they're pulling to a stand and they start cruising, walking while holding onto the furniture. Real walking usually isn't far behind.
So 6 months is the trigger for fall prevention from beds and couches. And 9 months is when you better have those stair gates up.
You better.
Now for fine motor skills, the manipulation.
Fine motor is all about purpose and intention. At 4 months, their hands become toys. They're batting at objects, bringing their hands to their mouth, holding a toy if you put it in their hand.
And then at 9 months.
At 9 months, you see the development of the gross pincer grasp. They use this raking motion with their whole hand, and they can transfer objects from one hand to the other.
Which means everything is going in their mouth.
Everything. This is prime time for choking hazards. Then, at 12 months, you get the culmination.
Yeah.
the fine pincer grasp.
Using just the thumb and index finger.
Precisely. And that skill is a huge physical marker for their readiness to handle small finger foods safely.
Okay, let's jump into the theory that explains why they're doing all this. We have to start with Piaget's sensoromotor stage.
Right, which dominates this whole period. Piaget basically said the infant learns through their senses and through movement. It's this rapid evolution from just pure reflexes at birth to simple repetitive acts like sucking their thumb, and then to repeated actions that are intended to get a result, like shaking a rattle to make a noise. That shows they're developing intentionality.
But the single most high-yield cognitive concept here is object permanence. This is a game changer.
Object permanence is the understanding that an object or a person still exists even when it's out of sight. It really solidifies around 8 months of age.
And clinically, why is this so profound?
Because its achievement directly enables the emergence of stranger anxiety and separation anxiety.
Okay, so connect those dots for us. Frame it like a nurse explaining this to a worried parent.
Absolutely. So I'd tell the parent that object permanence is like the birth of worry for the baby. Before 8 months, if you leave the room, it's sort of out of sight, out of mind.
Right.
But once object permanence kicks in, the baby remembers that you exist even when they can't see you. They realize your departure is a real thing, and maybe, just maybe, you're not coming back.
So that new distress is actually a sign of cognitive success.
It's a huge cognitive success. It's not a failure. The nurse's job is to reassure the parent that this anxiety is normal, it's temporary, and it's a healthy milestone. It shows their memory and attachment are developing beautifully.
That reframing distress as success is a fantastic piece of anticipatory guidance.
It really helps, and as they get closer to 12 months, we see the beginnings of mental representation.
Using symbols.
Exactly, the ability to use symbols. This is why a 12-month-old can wave bye-bye and know what it means. They're starting to move from the purely tangible to more abstract thought, which is the gateway to language.
Okay, now let's layer on Erickson, the psychosocial foundation. Trust versus mistrust. This feels like the emotional bedrock for everything else.
It is the core task of the first year of life. The infant has to achieve a fundamental sense of trust in the world, and that trust is entirely dependent on the quality of that caregiver-infant relationship.
So what's the mechanism for building that trust? And what's the NCLEX trap about spoiling a baby?
The mechanism is a consistent, reliable response to the infant's basic needs. It's that simple.
So when they cry, you respond.
When they cry from hunger or discomfort or fear, and the caregiver responds promptly and consistently, the infant's nervous system literally learns that the world is a predictable, safe place. The trap and the common parental fear is that responding so quickly will spoil the baby.
And the nurse's job is to bust that myth.
Yes. The nurse has to explain that in this stage, trust versus mistrust, it is physiologically impossible to spoil a baby. You are not creating a bad habit. You are building neurological pathways of safety.
If that doesn't happen.
Failure to learn that their needs will be met leads to frustration and the development of mistrust. In severe cases, this can manifest as reactive attachment disorder or contribute to failure to thrive. We have to stress that consistency builds resilience, not dependence.
Okay, what about primitive reflexes? This feels like a nice-to-know detail, but it's really important for neuroassessments.
It is. It's maybe secondary to the motor milestones for some exams, but knowing the timeline for when these reflexes disappear is essential, because if they stick around too long, it's a classic neurological red flag.
It's that transition from involuntary responses to voluntary learned control.
That's exactly what it represents.
So give us the key timeline.
Okay, the rooting and suck reflexes disappear pretty quickly. Around 3 months for rooting, 2 to 5 for suckling. The Moro, or startle reflex, and the asymmetric tonic neck reflex, that fencing posture, they both should be gone by 4 months. A persistent Mora past that point is a big indicator of a CNS maturation delay.
What's next?
The palmar grasp disappears between 4 to 6 months, right when voluntary grasping starts to take over. The plantar grasp in the feet is gone by 9 months, just before they need to start bearing weight to cruise.
And the big one.
The Babinski reflex, where the toes fan out, that should be gone by 12 months. After that, a positive Babinski is a pathological sign in anyone older than a baby.
So it's this neat chronological shutdown of all these involuntary systems as the voluntary brain takes over.
A rapid-fire closure, exactly.
Okay, so this next section covers the stuff that really makes up the bulk of every well-child visit. This is where we are proactively protecting the infant.
Absolutely. High-yield health promotion. immunity, nutrition, and sleep.
Let's start with immunizations. This is a core nursing responsibility. We need a clear mental framework for that primary series in the first year.
Okay, we need to anchor to the timing and the composition of the shots based on CDC guidelines. At birth, they get their first dose of hepatitis B.
Critical for preventing vertical transmission.
Very critical.
No.
Then you have the primary series. This happens at 2 months, 4 months, and 6 months. It's this high-yield cluster of shots.
Okay, let's break down the acronyms.
You've got DTaP, diphtheria, tetanus, and a cellular pertussis. Pertussis, or whooping cough, is a huge risk for infants, so this one's critical.
Right.
Then RV for rotavirus. This one is unique. It's given orally, not as a shot.
And it protects against that horrible diarrheal illness.
Exactly. Then you have IPV for inactivated poliovirus, HUB for Haemophilus influenza type B, which prevents things like bacterial meningitis, and PCV, the pneumococcal conjugate vaccine, which protects against a major cause of ear infections and sepsis.
And Hep B fits in there again, too.
It does. The final dose of the Hep B series often falls in that 6-month window, or a little after.
I can't forget the flu shot. When does that come into play?
The inactivated influenza vaccine is recommended every year, starting at 6 months of age. It's crucial because infants are at such high risk for complications from the flu.
Now for the critical nursing implication, route and site. This is a huge exam point.
It is. For almost all of these routine infant immunizations, the required route is intramuscular or IM injection, and the high-yield site is the vastus lateralis muscle.
The big muscle on the anterolateral thigh.
That's the one.
So why there?
Yeah.
And why is the gluteal muscle, the buttock, so strictly off limits?
The rationale is all about anatomical safety. The vastus lateralis is the biggest, most developed muscle in an infant. It gives you the lowest risk of hitting a major nerve or blood vessel.
And the glute.
The dorsogluteal site is contraindicated until a child has been walking for at least a year, sometimes more. The sciatic nerve is still relatively superficial in an infant, and the risk of permanent nerve damage from a shot there is significant. It's just not worth the risk.
Okay, that makes sense. Let's move to nutrition. This is another area with some major NCLEX traps.
The shifts in nutrition are profound, and they require very specific guidance for parents.
Let's start with the basics. Milk and what's forbidden.
Breast milk or formula is the absolute cornerstone of nutrition for the entire first year. And the absolute non-negotiable NCLEX rule is that cow's milk is not recommended before 1 year of age.
Why the strict cutoff? What's the physiological reason?
It's threefold, really. First, the renal load. Cow's milk has a high amount of protein and minerals, which is really hard on an infant's immature kidneys.
So it could cause dehydration.
It could. Second, iron. Cow's milk lacks sufficient iron, and it puts the infant at risk for iron deficiency anemia. And third, it can interfere with the absorption of essential fatty acids that they need for all that brain development we talked about.
Speaking of nutrients, let's talk about the critical need for vitamin D supplements. This is a famous NCLEX trap.
It's tested so often because it's often overlooked in practice. All breastfed infants require vitamin D supplements. 400 IUs per day, starting in the first few days of life.
Even though breast milk is the gold standard.
Even though breast milk is amazing, but it just doesn't have enough vitamin D to prevent rickets. Now, if an infant is getting 28 ounces or more of fortified formula every day, they don't need it. But for breastfed babies, it's non-negotiable.
Okay, now for the big moment. Introducing solids. We said around 6 months, but what are the actual clinical signs of readiness a nurse should be looking for?
It's driven by development, not just the calendar. You're looking for 3 key signs. 1, voluntary head and trunk control. They have to be able to sit up with support. 2, the extrusion reflex has to disappear. That's the tongue thrust that pushes food out.
Right.
And 3, they just have to show interest in watching others eat.
What's the protocol for introducing them? How do we watch for allergies?
The method has to be systematic. You introduce 1 single ingredient new food every 3 to 4 days.
Do you have time to see a reaction?
You have time to monitor for any subtle signs of an allergy. A rash, swelling, diarrhea, vomiting. You usually start with an iron-fortified rice cereal or oatmeal because the mom's iron stores that the baby was born with start to deplete around 6 months.
And what about other fluids? What's the rule on water?
No water before 6 months of age.
None at all.
None. The infant's kidneys are still maturing, and giving them water can actually lead to water intoxication or hyponatremia.
Oh.
After 6 months, small sips are fine, and we really recommend limiting juice entirely and introducing a cup around 6 months to start working on those oromotor skills.
All right, let's talk sleep. And we have to start with the single most critical safety directive in all of infancy, SIDS prevention.
This is a high-yield safety rationale that is taught at every single visit. The core directive is to place infants on their back to sleep, the supine position.
Always.
Always. This has been proven to dramatically decrease the risk of sudden infant death syndrome. The rationale is physiological. The prone or stomach position is associated with rebreathing carbon dioxide, which can lead to hypoxia in babies with immature arousal mechanisms.
And the sleep environment itself has to be strictly controlled.
This is where clear anticipatory guidance is paramount. A safe sleep environment means a firm mattress that fits snugly in the crib. And crucially, there should be nothing soft in that crib.
Nothing at all.
No pillows, no loose blankets, no bumper pads, no soft objects, no stuffed animals. These are all suffocation risks.
So as the infant gets more mobile, their risk profile changes constantly. The nurse has to shift from just being a caregiver to almost being a proactive risk consultant.
That's a perfect way to put it. The core mental model is this. Infants are mobile explorers, and they explore everything with their mouths. Our guidance has to evolve based on that reality.
Okay, let's start with the highest stakes safety item, car seats. And let's not just state the rule, let's explain the biomechanics of why it's so strict.
The rule is based on protecting the infant's most vulnerable structure, their cervical spine, and the rule is absolute. Car seats must be in the federally approved rear-facing position until the infant is at least 2 years old.
2 years old, or they hit the height and weight limit.
Or they reach the maximum height and weight limit set by the manufacturer, right?
Tell us about that whiplash effect in infants. It's terrifying.
It is. The nursing rationale comes from the fact that an infant's head is about 25% of their total body weight.
A quarter of their weight.
A quarter. Compare that to about 6% in an adult. Their neck muscles are weak, their ligaments are immature. So in a frontal crash, if that child is forward-facing, their heavy head is thrown violently forward.
And the stress on the spine is immense.
It can cause what's called an internal decapitation or a severe spinal cord injury. It's catastrophic. Rear-facing distributes those crash forces across the strong shell of the car seat and the strongest part of the infant's body, their back. It is non-negotiable life advice.
Absolutely. Next up, aspiration and choking, which is tied directly to that oral exploration.
Since the mouth is their primary tool for interaction, everything goes in. So the guidance has to stress checking every environment for small objects. Buttons, coins, deflated balloons, small toy parts, and hard round foods like whole grapes or hot dogs cut into circles.
The toilet paper tube test.
The cardboard toilet paper tube test is a great tool. If an object can fit through it, it's a choking hazard.
Let's talk about drowning risk. This one often surprises parents because it can happen so fast and in such a small amount of water.
Drowning is terrifyingly rapid and often silent. It only takes an inch or two of water. The rationale is that infants have poor head control, they can't push themselves up, and their weight distribution pulls them head first.
So what's the guidance?
Never, ever leave an infant unattended in a bathtub, not for a single second. And you have to secure access to pools, hot tubs, even mop buckets and toilets. A simple toilet lid lock is a high-yield safety measure.
Poisoning risk shoots up once they start crawling.
As soon as they're mobile, you have to assume they will get into everything. So cleaning chemicals, medications, alcohol, all of it needs to be in child-proof containers and stored high up, preferably in locked cabinets.
Got it. What about burns, especially from bathwater and in the kitchen?
Infants have thin, sensitive skin that scalds much faster and deeper than adult skin. So the key interventions are: 1, set your hot water heater thermostat below 120 degrees Fahrenheit or 49 Celsius.
It's a huge one. It's always on exam.
Always. 2, in the kitchen, always turn pot handles inward on the stove. 3, never warm formula in a microwave. It creates dangerous hot spots. And 4, use sunscreen and shade for infants over 6 months and strict shade for those younger.
And finally, falls. The most common injury sending this age group to the ER.
Falls are basically guaranteed once they're mobile. The guidance is simple. Never leave an infant unattended on an elevated surface. Not a changing table, not a sofa, not your bed. They can learn to roll in an instant.
And baby walkers. The mobile ones.
We have to strongly counsel against them. They are inherently unsafe. The rationale is twofold. They give the infant dangerous speed and access to hazards like stairs before they have the control to navigate them, and they can actually impede normal walking development.
Okay, let's connect play directly to development. We're talking about solitary play in infancy.
Right. Solitary play means the infant plays alone, focusing on their own body and their immediate environment. And the toys should match their evolving skills.
So for early infancy, 0 to 6 months.
You want sensory and oral fixation. Think soft stuffed toys, teething rings, rattles, and unbreakable mirrors.
Mid-infancy, 6 to 9 months.
Now they're learning cause and effect and object permanence. So simple blocks that are too big to swallow, playing peekaboo, things they can bang to make a noise.
And late infancy, 9 to 12 months.
This is all about fine motor refinement and getting ready to move. So you want nesting toys, stackable cups, big picture books to promote language, and push-pull toys once they start walking.
So this final section is all about the nurse's role in developmental surveillance. We're looking for those deviations.
Exactly. And if these warning signs are observed or reported by a parent, it requires immediate referral.
Let's run through the red flags, starting with hearing and vision.
For hearing, a big warning sign is if the baby does not make sounds or babble by 4 months, or if they don't turn their head to locate a sound at 4 months.
And vision.
If their eyes are crossing most of the time strabismus at age 6 months, that needs a look. Or if they don't track or follow an interesting item smoothly with their eyes.
Language is a huge marker. What are the specific language red flags?
We're looking for the absence of expected sounds. So if the baby doesn't laugh or squeal by 6 months, if they're not babbling by 8 months, and a big one if they're not using single words with meaning like mama or dada at 12 months.
And the motor red flags tie right back to those milestones we discussed.
They do. Lack of head control by 4 months is a big one. No rolling by 6 months. No sitting unsupported by 9 months. And socially, a persistent lack of interest in interaction is a huge red flag that undermines that whole trust versus mistrust foundation.
Okay, let's cover some of those common developmental concerns that aren't emergencies but drive a lot of parental calls. Dentition.
The first teeth usually erupt between 6 to 8 months. For comfort, you want to recommend cold objects, frozen teething rings, and it's crucial to tell parents that ibuprofen or acetaminophen should only be used under a provider's guidance and only for infants over 6 months of age.
And how do we prevent baby bottle tooth decay?
You have to stress cleaning the gums and teeth daily with a soft cloth. And the absolute key is to avoid bedtime bottle propping. Never put a baby to bed with a bottle of milk or juice. The sugars just sit on the teeth and cause rapid decay.
Colic. The most frustrating issue for new parents.
Clinically, we use the rule of threes. Crying for more than 3 hours a day, more than 3 days a week, for more than 3 weeks. It usually resolves by 3 months.
So the intervention is mostly supporting the parents.
It's heavily focused on parental coping mechanisms. We validate their distress and stress the importance of taking breaks. If the crying is overwhelming, it is safe to put the baby in the crib and step away for 15 minutes to regroup.
What about spitting up or a simple reflux?
Very common. The guidance is direct. Keep the infant upright for 30 minutes after feeding, loosen their diaper, and don't lay them on their stomach right after a meal.
And thumb sucking or pacifiers, are they okay?
Yes, they are normal, healthy comfort mechanisms. We generally don't intervene during infancy. It's a part of self-soothing and aligns perfectly with that sensory-motor stage.
All right, let's wrap this up. If you remember nothing else from this entire deep dive, what should it be?
If you're walking into an exam or onto a pediatric unit, you need to focus on this fundamental nursing assessment triad for the infant. This is your 20%.
Okay, let's hear it.
Number 1, safety first. Rear-facing car seats until at least age 2. Back to sleep, always. And hot water heater below 120 Fahrenheit.
Got it. Safety.
Number 2, growth milestones. Remember the pattern. Weight triples by 1 year. Developmentally, fine pincer grasp at 12 months, sits unsupported at 9 months. And if they're a preemie, use the adjusted age.
Milestones and adjusted age. And number 3,
Trust versus mistrust. Consistent, reliable, prompt care is the foundation. Your role as the nurse is to teach parents that responsive care in the first year builds trust and resilience, not dependence.
this high-yield focus really does streamline your study, connecting that theory directly to clinical actions. We've covered the vitals, the trust foundation, the safety evolution, and that non-negotiable immunization schedule. We really try to replace just listing facts with the clinical rationale behind them.
And if we connect this to the bigger picture, this whole infant period is just defined by explosive brain growth and the consolidation of the nervous system. You see it in the head circumference, the closing fontanels. So this raises an important question for what comes next.
Okay.
When an infant becomes a toddler, how do we differentiate a true problematic developmental delay that needs immediate intervention from just a simple pause in their learning? especially since that major physical growth spurt and the closing of those neurological windows have ended. How does our surveillance model have to change when the pace of physical growth slows way down, but cognitive development just takes off?
Something to mull over as you prepare to transition to the next stage of pediatric learning, the toddler. You've successfully navigated the infancy deep dive.